Good morning and welcome. I'm Julia Cartwright, Senior Associate Dean of Communications here at New York University School of Global Public Health. Thank you so much for joining us for an in-depth conversation about monkeypox. First, some housekeeping issues. Please submit your questions via the Q&A box, and we will get to as many as we possibly can in the limited time we have together. Also, please connect with us on Twitter. And now it is my privilege to introduce our terrific new dean, Dr. Deborah Furr-Holden. Dr. Furr-Holden is a renowned scholar, epidemiologist, and biostatistician. So with no further ado, please join me in a warm welcome to Dr. Furr-Holden.
Thank you for that, Julia. I know we've all got a lot of anxiety around this new emerging public health crisis. And so our goal really today is to make sure that we can put people at ease and give you the best information that we have at the time. There are currently more than 18,000 cases of monkeypox worldwide, but the US holds this terrible distinction of having the most cases reported so far in the outbreak. So what we want to do is clarify some things for people, let them know what monkeypox is, how it's spread, and what can be done to safeguard the public. And I, as your new dean at the NYU School of Global Public Health, have the great honor and privilege of working with some of the nation's leading epidemiologists. So I've invited 3 faculty right here from the NYU School of Global Public Health to answer questions and, get this conversation started and give people what they might need. So here's a quick primer on monkeypox. It's a viral infection. It causes flu-like symptoms that include things like exhaustion and these very painful lesions. And for people who know people with monkeypox, people will tell you early on it might feel like a mosquito bite or something like that, but it is in fact something that's very painful and has been quite an ordeal for people to deal with. It can be spread through skin to skin and face-to-face contact. And we're going to hear more about how it might spread through the air and respiration from some of our experts. And while there's currently no treatment, there is a lot that we can share about prevention and currently vaccines, and also what the prognosis might look like. And here in New York City, a vaccine is available for those who've been exposed to the virus, especially in those in this high-risk group that we've heard a lot about, our brothers and sisters in the LGBTQ+ community who are eligible. So now I'd like to turn it over to my wonderful 3 colleagues, leading epidemiologists at the NY School of Global Public Health. And the first is Dr. Danielle Onpad. Her work primarily focuses on urban health, HIV, illicit drug use, and adult use of vaccines. Many people in New York and even abroad may know Dr. Onpad because she's been at the forefront of much of the credible information dissemination surrounding the COVID pandemic. Also, we have with us today Dr. Farzana Kapadia. She specializes in the social and structural drivers of HIV and other sexually transmitted diseases, as well as a global focus on sexual and reproductive health. And then last, but certainly not least, we have Dr. Dawn Desjarlais, who is a giant in the field, one of my heroes, and has been a front runner and at the forefront of conversations around HIV and injection drug use. So I want to turn it over to Dr. Onpad and let her just give us a little bit of a primer from her lens around what we think people need to know about monkeypox. So Dr. Onpad.
Hi, everybody. Thanks for joining us. We're really excited to have you here. And thanks, Dr. Furr-Holden, for such a gracious introduction. So I'm going to tell you guys a little bit about monkeypox. So monkeypox is an orthopox virus, and it's related to smallpox, cowpox, and Vaccinia virus. And it causes less severe disease than smallpox used to. Remember, smallpox was eradicated in the early 1980s. Now, interestingly, monkeypox is not related to chickenpox, even though they both have pox in the name. Chickenpox is actually a herpes virus. So how do you get monkeypox? You can get monkeypox in different ways. The virus can spread from person to person through direct contact with the infectious rash or the scabs or body fluids, from respiratory secretions during prolonged face-to-face contact or during intimate physical contact, such as kissing, cuddling, or sex, from touching items like clothing or linens that have previously touched the infectious rash or body fluids. And pregnant people can spread the virus to their fetus through the placenta. It's important to note that we are not sure yet if monkeypox can spread through semen or vaginal fluids. However, we do know that close physical contact with the rash is a source of transmission. The other thing I just wanted to mention is that there are 2 licensed vaccines for monkeypox in the United States. And it's important to note that even though we have a chickenpox vaccine, the chickenpox vaccine does not provide protection against monkeypox. So we have 2 vaccines in the US. One is ACAM 2000, and this is a 1-dose vaccine that is administered by scarification. So what does that mean? So if you are old enough to have had a smallpox vaccine, and we stopped doing that in the US in the 70s, what they would do is they would put a drop of the vaccine on your arm, and they would use this little 2-pronged fork that was sharp, and they would kind of stab your arm very gently with the fork to create a scar where the vaccine would go through. And so the ACAM 2000 vaccine is a 1-dose vaccine, and it is for smallpox, but it's also for monkeypox. The other vaccine is Jynneos, and this is a 2-dose vaccine that is given with a syringe in your arm. It's subcutaneous, or basically under the skin. This is a live vaccine, as is the ACAM 2000, and it's also approved for smallpox and monkeypox. Both of these are live vaccines, and they use the Vaccinia virus to vaccinate us against monkeypox. So that's what I wanted to cover today. If any of my colleagues want to chime in, please feel free.
Yeah, we want to hear quickly just a high-level overview from Dr. Kapadia. And Danny, thank you for that basic foundation for us. Dr. Kapadia.
Yes, thank you. Thank you, Dr. Umpad, and thank you, Dean Verholden, for having us today. And thank you to all the attendees. So my goal today is just to discuss some of the global inequities in the response to monkeypox, and how we can begin to attenuate those inequities. So monkeypox is a condition that really lays bare these inequities in not only health and healthcare, but also the types of public health research that we value and pay attention to. In Central and Western African countries, monkeypox has been endemic since the first case was detected in humans in the Democratic Republic of the Congo in 1970. And in fact, there have been dozens of outbreaks of monkeypox in Western and Central African countries. And even though the likelihood of dying is fairly low, the bulk of cases of deaths, have been among residents in these countries. So up until the present outbreak, monkeypox really never left Africa. Most cases were in rural areas and among hunters, among women, among children, generally among people who didn't historically travel outside of those countries. But those earlier outbreaks also allowed investigators in Western and Central Africa to conduct substantial research on monkeypox. And it was after a 2017 outbreak in Nigeria that investigators there first discovered that there may be some person-to-person transmission in addition to animal-to-human transmission, or what we call zoonotic transmission. So the story of monkeypox is not just a story about a neglected disease, but it's really one that's been largely ignored, as the bulk of cases and deaths have been in Western and Central African countries. So with the current pandemic and with a large number of cases in Western Europe and North America, there's a lot of attention that's being given to monkeypox, and rightfully so. But how do we prevent the inequalities in the response that we've just witnessed with COVID-19, with the COVID-19 pandemic, from happening again with monkeypox? Well, countries in Western Europe and again in the US and Canada have been stockpiling smallpox vaccines. And expensive contracts with the Danish firm that's making the current vaccine supply are already in place. In fact, the US just announced the plans to distribute 800,000 doses of monkeypox vaccine. But globally, public health officials have no clear path for how poorer countries are going to be able to get vaccines, since stockpiling in those countries is not really possible. So the first question is, will the nations that have stockpiles be able to share their vaccine doses with countries that can't afford to stockpile? And if so, can we implement target vaccination programs in those countries that can reach healthcare workers, that can reach lab technicians handling tests, that can reach those who are immune compromised, that can reach those who frequently encounter wildlife, which is, as we know, a main source of transmission. Second, in countries beyond like Nigeria and the Democratic Republic of the Congo that also have monkeypox outbreaks, how can we support and enhance the capacity to conduct timely testing, to maintain surveillance systems that allow us to more rapidly identify cases, identify clusters, and identify epidemics in those countries? Because that's how we begin to implement containment measures. So the bottom line is that, the solutions that we have and that we think will help to stem the pandemic in Western countries, Western European countries, and in the US and Canada, can't ignore what's happening globally. We need to have a global response that takes into account what the local needs are of these countries.
Wonderful. Dr. Kapadia, thank you for that. We've got a lot of questions rolling in the Q&A, so I'm definitely going to be coming back to you because people are already asking questions about local resources. Dr. Jarlais, I know you've done a lot. You were really at the forefront of our HIV response. Could you just chime in and give us a quick kind of high-level overview about things we need to be thinking about related to stigma and potential spread in our communities?
Yes, stigma is one of the critical issues in trying to control monkeypox. It is fundamental to public health control of all infectious diseases. If you look at the history of infectious diseases, you see two basic human responses. One is to shun people with the disease, to isolate them, and often just to punish them. The other basic response is supportive, to try to care for, help, and cure people with the disease. And these two basic instincts are often in conflicts, and the charge for public health is trying to balance those. For public health measures, you need to identify people with the disease and at risk for the disease, do contact tracing, limit the spread. But if you identify people with or at risk, there is the danger of stigmatizing those people. Stigmatization can lead to very severe negative consequences. For COVID, we saw a great increase in anti-Asian hate crimes as a result of stigmatization. Stigmatization can also lead people with the disease to avoid being identified, to avoid seeking healthcare, and further transmitting the disease to others. So managing stigmatization is one of the primary concerns in trying to control an outbreak of an infectious disease. The classic example of this conflict may be Hansen's disease in Hawaii, where people with Hansen's disease were confined to a small isthmus on the island of Molokai. There was basically no access to that isthmus other than boats coming across the different islands. To get to this isthmus from the rest of Molokai, you had to descend 1,000-foot cliffs that were basically vertical. So it was, unless you had a good donkey, you were likely to die trying to get there. So while people with Hansen's disease were confined to this very isolated location where they did not have any contact with friends, relatives, or anything, there was a Roman Catholic priest named Father Damien who went and administered to the people with Hansen's disease. And he was made a saint. So we have this bifurcation of isolating, shunning people with a disease, and then making the person who did the most to help them a saint. So we basically were doing very, very bad things to these people by isolating them and still honoring the person who provided comfort to them. We've seen parallel stigmatization with SARS-1 that broke out in China in 20,000, with AIDS, with COVID, and we're seeing it with monkeypox right now. There have been various debates within the World Health Organization and within the New York City Department of Health as to what sort of public messages should we send about monkeypox. Do we tell people this is currently largely confined to men who have sex with men and risk stigmatization? Or do we try to make this more general so that the stigmatization might be reduced? We are seeing very, very rapid changes in the public health messaging. About a week ago, there was a story in the New York Times about the internal debates within the New York City Department of Health as to what extent should men who have sex with men be mentioned with respect to monkeypox. That was also, the debate was occurring in the World Health Organization. Within the last week, we have seen movement towards more explicit messaging around the dangers that men who have sex with men are facing. Yesterday, the World Health Organization came out with a recommendation for men who have sex with men to reduce and limit their numbers of sexual partners and to not have anonymous sexual partners, which defeats contact tracing. So we're seeing rapid movement with more specific public health messaging, and we are going to have to develop ways in which people at high risk for this disease feel empowered to change their behavior and feel supported and protected by the public health establishment to minimize the chances that things like hate crimes may occur. So it's going to be a difficult task for public health officials, but it is a very, very urgent one if we're to bring this outbreak under control and before the disease becomes endemic in society.
Dr. Jarlais, so I have a burning question for you, which is, you brought up this very interesting group of men who have sex with men, and I feel like they have been greatly stigmatized in the sort of messaging around monkeypox. So what you're saying, it sounds like, is that this is not a men who have sex with men only disease. Are we all at risk for monkeypox?
We are potentially all at risk right now. About 98, 99% of the cases are among men who have sex with men. However, it is not a sexually transmitted disease. It can be transmitted by just skin to skin contact. There may be aerosol transmission, so that we should all be concerned about it. The level of concern obviously should vary with the level of risk, but what we have to do is give accurate information, but bring the groups at various levels at risk along with that messaging, to include them in the messaging, to empower them to take precautions and make sure that they feel supported rather than stigmatized. That is not an easy challenge for public health, but is the major one we face right now in trying to control this epidemic.
Gotcha. Thank you so much. Dr. Kapati, I have a question for you. So Dr. Jarlais mentioned this term endemic, and us trying to bring this to a close before it becomes endemic. So you had mentioned something earlier about it being endemic in certain parts of Africa. What then are you saying has caused the spread here, and what can we do to prevent it from becoming endemic?
Right. So endemic means that it's a disease that occurs periodically in a country. We'll see cases arise, we'll see clusters, we'll see small outbreaks. The transmission or the increase in cases outside of Africa is largely due to the fact that the way it's transmitted has changed, has evolved. It used to be just a disease that was spread by being in contact with the animal reservoir, which are mice, rats, shrews, squirrels. And so this is really why it was a rural disease. But as it's evolved and become something that's transmitted person to person, this is where we're seeing more cases that are happening outside in other countries. Can it become endemic in other countries? I wish we had a magic 8-ball that could answer that question for us.
Yeah.
As with COVID, we're seeing what happens as the pandemic, evolves, as our access to vaccines increases. But as long as there is an animal reservoir, we'll continue to see cases and outbreaks. How transmission changes and evolves in Western Europe and in North Africa and in Canada will determine whether and how it becomes endemic, meaning we see outbreaks occurring in other countries outside of Western and Central Africa.
Yeah.
Well,
So
one aspect of it becoming endemic in the US would be whether it develops an animal reservoir in the US like it has in Western Africa. Right now, we don't have any evidence of an animal reservoir, but we certainly have lots of small rodents in this country, including in New York City. And so we need to bring this outbreak under control before we get transmission from humans to animals, and then continuing transmission among animals and from animals back to humans.
great. This is great. We've got a few questions that have popped up in the Q&A that I want to get to. And so I'm going to put two together. The one question says, why is it that men who have sex with men are at higher risk? And then another question that follows on that, it says, we just came off of Pride Month and multiple gatherings. Why are we not being more proactive, given that we know we had these sort of international events that brought people in a certain community together to celebrate something that I think we as a society have decided we want to make sure we're an inclusive society. So anybody want to chime in on that? I'll open it up for any of the panelists. Why are we seeing more cases of men who have sex with men? And do you think there's some connection with the fact that we just had a month-long set of celebrations celebrating people, in different communities?
So I can take that question. I think one of the reasons why we're seeing more cases in the gay community is there was probably some cases among that community in the beginning. And then, as you said, because there have been many large gatherings in the month of June to celebrate Pride, that probably exposed people. Because remember, in terms of transmission, being in contact with the rash is one of the main ways to transmit it. So if you're, in a crowded event, could be a party, could be a bar, could be a parade, and you're standing next to somebody who has a rash, you are potentially exposed, and that's how it could have been transmitted. I do want to say, we should be thinking for that community to make sure that we're getting information out, that if you were at any large events, you want to monitor yourself for symptoms. But that doesn't mean that other large events that were not Pride affiliated or not part of LGBTQ community celebrations are exempt from potential transmission. So any concert that you go to, any event that you're going to where there are large crowds, there is the potential for transmission, particularly if you're standing right next to people. And the challenging thing is, I think, as you said, Dr. Verholden, is that in the beginning, these sores may feel and look like bug bites. They may look like mosquito or flea bites, right? So they're going to be red. There may be like a little pustule or blister that pops up. And that's what happens like when I'm around a dog that has fleas. I'm a little allergic to flea bites and I get these big welts. That's kind of what it looks like. So people may not even realize that they have monkeypox because it's the season when we're getting bug bites. So it's really important for people to kind of check themselves out. If you have some sores that you're not sure where they came from, just go ahead and get checked out and then try to stay away from folks until you can figure out what it is.
Gotcha. And so now we are learning that that this virus can actually be spread through respiratory droplets, and maybe even from oral fluids. And I want to be super clear. The information and our understanding of this is evolving. But there's a question. And what's the risk? Do we know much about the risk from respiratory transmission and other sort of causal contact with cases? Are you at risk if you hug somebody who has monkeypox? And I feel like you sort of touched on it, but I just want to honor the question and make sure we give an explicit answer. What do we know right now about respiratory risk and other causal contact? I'm sorry, not causal, casual.
Yeah.
Casual contact. You're not having sex with somebody. You just encounter a friend who you bump into on the street and you haven't seen in a while, and we're all out of COVID and happy to look each other in the face and give a hug. Are you at risk?
You are at risk, unfortunately, because the lesions do tend to show up in all sorts of places, right? So if somebody has a rash and you hug them and you touch skin to skin, or even on their clothes, right? Because remember, I said that contaminated surfaces. So if the rash touched the clothes and then you touch the clothes, you could potentially be exposed to monkeypox. In terms of respiratory secretions, absolutely, it is a risk. And so I haven't seen data to say, how much of a risk it is, but we do know it's one of the ways monkeypox can be transmitted. So we do want to be careful. Many of us are still social distancing or wearing masks. That could help, but it's not one of the recommendations for preventing monkeypox.
All right, great. Thank you so much, Dr. Onpad. Literally, our New York State Commissioner of Health, Dr. Mary Bassett, just yesterday issued a declaration that monkeypox poses an imminent threat to New Yorkers. What is the mortality rate? When I think about a threat, right? Like there's the getting sick, and then there's that ultimate thing that you can't come back from, which is dying or succumbing to the illness. What do we know right now about the death rate of monkeypox?
So I can speak. Oh, go ahead, Dr. Jarlais.
Okay, we do know that of the cases in the US and Western Europe, there have been no deaths so far, which is very, very encouraging because those are over 10,000 in those two. One other comment on skin-to-skin transmission, that the chance of transmission goes up with prolonged skin-to-skin transmission, that shaking hands or a brief hug is very, very low risk compared to the prolonged skin-to-skin contact that you might have with being in a crowded dance or engaging in sexual activities. So don't be paranoid that if you go out and you brush against somebody on the subway, that you're likely to get monkeypox. You're not very likely through that type of brief skin-to-skin contact. It's the prolonged contact that really ups the chances of transmission.
All right, Dr. Kapadia, you wanted to jump in, but I want to ask you something specific, and you can offer whatever else you want to. But we're still in the state of a pandemic, right? We're still very much dealing with COVID. And, we have varying opinions about how well we did as a, public health community and a medical community, and how great our governmental response was or was not. What did we learn from COVID that we should be applying here? Like, what did we get from that could help us, better manage our response to this, potential now looming public health crisis?
Well, thanks. It's a big question. And I wanted to jump on and add something what Dr. Jarlais said about understanding this disease. And in terms of also the response to COVID, one of the most pressing needs right now is to make sure that we have testing, accurate testing, and reliable and efficient and rapid testing. And that's one of the reasons why we don't fully understand deaths due to monkeypox, because often they go untested, undiagnosed. So if you don't know if someone has monkeypox, you don't know if they die, you don't know what they've died from, right? So that's one thing we really need. And that's part of our response right now is we need to be able to roll out testing, and we need to be able to roll out information on what the signs and symptoms are to the groups that could be most affected, but also to the general population, right? So not just talking about the LGBTQI+ community, but to the general populace. The second thing is we need to support efforts to conduct surveillance, right? Both here in the US and in Western Europe and Africa. Right now, monkeypox is not a notifiable condition, which means that if you're if you're a physician testing someone who has monkeypox, it's not something that has to be notified to your local health authority, and then that filters up to the CDC. It's going to become one soon, rapidly, but that's something that hasn't been done yet. So we need that designation. And then also we need to activate our surveillance systems, right? Prevention and surveillance are the foundations of a good public health response. We can't know what to do until we know how widespread something is, and we know that rapidly and quickly. So we need that. And my forever plug is that we need to stop underfunding our local health departments, right? We've underfunded our local health departments historically, and that's why we've seen such a fractured response to the COVID pandemic, and we continue to witness the fractured response. And that's what makes this response to the monkeypox pandemic hard to manage as well.
Wonderful.
Clear, consistent guidance is what we need.
Wonderful. So I'm going to throw up for all of our listeners, if you're on by phone, this is going to be recorded. I just put up the link to what the state health department, the State Department of Health and Human Services has put up. And they agree with you, Dr. Kapadia. We really need to empower and resource our local health departments. Why? Because where people live is typically where they also receive their healthcare services and where they experience all of the opportunities for optimal health. So thank you for that. I want to switch a little bit and throw it back to you, Dr. Ompad. We learned during COVID, we were all told about this vaccine, and I think there was a little bit of mismessaging around what the vaccine would and would not provide by way of protection for the individual. We're now super clear. The COVID vaccines are working pretty good at preventing and reducing the risk of severe illness and hospitalization and death. We have a question about the monkeypox vaccines. Do they prevent transmission of disease? So, and I understand I'm sort of putting you in the hot seat because we're learning in real time, but what is the knowledge and information that we have right now, best and greatest, about what the vaccine does and does not provide by way of protection for monkeypox?
That's a great question. So the vaccines definitely are going to reduce the likelihood that somebody gets sick. Now, if you think about how monkeypox is transmitted, right? It is close contact with a rash. If you don't have a rash, you are not likely to transmit to somebody. Now, there also is some respiratory transmission, right? I suspect, although I haven't seen a lot of evidence for it, I don't know if you guys saw CNN this morning, but they were showing somebody who had a monkeypox infection and they had a sore throat, and they showed the inside of their mouth and they had all these kind of blisters in the back of their throat, right? I suspect that the respiratory transmission to some extent has to do with some of that rash in the throat that happened. So I would venture to say that the monkeypox vaccine reduces the likelihood of transmission.
Okay, great. So is this something where people can glean a little bit of what we learned about COVID, that it might not be a perfect solution, but it is going to maybe buffer some of the, negative and more severe effects of exposure and infection?
Yes, and definitely if people don't end up with rashes, the transmission from close contact is most likely eliminated altogether.
Okay, great. And just because I want to make sure we answered it explicitly, what's the mortality rate? Do we have numbers right now?
The mortality rate is relatively low. I think it's under 1%. It's definitely lower than COVID. The people who are most at risk for mortality or for dying are people who are immunocompromised. And so that would be people who are undergoing perhaps chemotherapy, or they have diseases which cause immunodeficiency like HIV or some other types of diseases. So those folks are at increased risk of mortality, but mortality generally is relatively low.
Okay, great. I want to
One-
pick up on a question in the chat. Dr. Jarlais, did you want to add something?
Yeah, one other thing about vaccines is that there's an urgency to them. If you've been exposed to monkeypox, you really need to get the vaccine within 4 or 5 days. If you get the vaccine that quickly, you are probably not going to get infected and therefore not going to transmit. But there's really a fairly short period of time between a real exposure and when the vaccines are going to be effective.
Great, thank
So-
you for adding that. Yep. So we have another question, and any one of you could pick it up. So we've talked a bit about mortality, but I want to shift to morbidity. And it's just what we know at the time. Do we have any sense of long-term or permanent complications? I myself saw a video this morning that one of my children sent to me, right? I'm a mom epidemiologist, so the kids are always coming to me, and then they put stuff out on social media, and they sent me a video of a young man who has monkeypox, and he sort of was describing his experience, and he was talking about it being very painful, and he was worried about scarring that might occur, right? And I think many of us can reminisce on our days of chickenpox and things like that. Do we know much about permanent complications beyond maybe just the skin scarring from the rashes or the blisters that people might get?
So you can get monkeypox lesions on your eye, and that can lead to permanent blindness. So we know that that can happen. There can be scarring. So because they are pox lesions, particularly if you scratch or you get a secondary infection. Because sometimes when you have rashes and you scratch, you kind of expose the rashes to other types of infections, other bacteria, and that can lead to complications as well as some scarring.
Okay, so now I want to thank you for that, Dr. Onpat. I want to pose a hypothetical question. I went out, I lived my best life. I had a fun time. A bunch of friends from college came to visit. I'm now in New York City. We went to some great place. We danced bachata all night, had a great time. And 4 or 5 days later, I get a blister or something on my skin. And then one of my friends also calls me and says, hey, I've got these, 2 blisters, or they kind of look like bug bites. What should I do? What is, if you think you have monkeypox, or that you've been out and you've been in close contact with people, you might not know that you had a known infection, but that you've been out and you've had close personal contact with multiple people in public settings. What should you do if you think you might have monkeypox?
Okay, the standard is to contact your primary healthcare provider and to isolate. Don't go out to large groups of people. Try to stay in where you live. Try to minimize skin-to-skin contact with other people. And your healthcare provider should be able to get testing for you. It's not a simple process. I've heard that it takes 2 hours worth of paperwork to get a test. But that it hopefully will change soon, because Quest Diagnostics has been authorized to develop testing on a commercial scale rather than the individualized testing that is occurring now. But contact a healthcare provider and isolate. Do not risk transmitting to others.
Is there some safe window of time? We sort of learned with COVID, right? Because we've all had COVID exposures, right? You went out to dinner and then you got a call from your friend 2 days later and they said, oh, I tested positive, or you might have been at a meeting or a family function and somebody called you. Is there some time window that we know about where one could expect, if they were exposed or if they have something that appears like a bug bite, that they could expect if in fact it was monkeypox, that they would have more outward symptoms, that even if they couldn't get a test, they could say, yeah, this is probably monkeypox?
So the incubation period, which is basically the time from when you were exposed to the time when you show disease, on average is 1 to 2 weeks, but it can be as short as 3 days and as long as 3 weeks. So if you think that you might have been exposed and you see a lesion, and it's in that window period, that incubation period, you might want to proceed as if you may have monkeypox until you can confirm whether or not you do. And by proceed, meaning, as Dr. Jarlais said, make an appointment with your healthcare provider to get tested. Depending on how long it's been since you've been exposed, you're going to want to isolate from people as much as possible, especially in close contact. And that's what I would recommend.
Okay, great. So I'm going to lean on some of my sexual health experts, because all of you guys, from Dr. Kapadia in reproductive health, Dr. Jarlais with the legacy in HIV, and Dr. Ompad, you working with injection drug users. Are these the kind of conversations you need to be having with people and sexual partners? Because if you talk about close personal and what Dr. Jarlais said, prolonged contact, it would seem that you might be at heightened risk for exposure through contact with sexual partners. Any ideas or suggestions about how people navigate these conversations with people that they have closer and more intimate relationships with?
One little thing before going on to that question, when we talked about isolating, that should involve isolation from bedclothes and towels and things like that, because there is a potential for transmission there. So if you are isolating and you're living with people, you would want to have your separate sheets, you would want to have separate towels and everything, so that the isolation includes potential transmission through things like sheets and towels. Just to
So
add that.
Now you're talking about the people that you live in the house with.
Yeah.
So the best way to protect people in the house is, you're saying, so if my daughter likes to climb in bed with me and I think I could have been exposed, you're saying we shouldn't do that.
Yes. Yes.
Gotcha. And we have data that suggests that it can be spread through bed sheets and linens and things like that.
Yes, we do have that data.
If I have a lesion, should I cover it? What if I have a lesion on the back of my leg? Should I not sit on the family couch? Should I cover the lesion? This makes me think of chickenpox and some of these other conditions. What should I do to protect people in my house?
There's not a lot of great data on that, but you probably should cover any lesions you have, and you definitely do not want somebody else's skin to come into contact with those lesions.
Okay, gotcha. Thanks so much for that. All right, close personal contact, sexual partners. Since we now know, we dispelled the myth that this is something that is just isolated in men who have sex with men. We are all at risk. Anybody you're coming into close, prolonged contact with, you have the greatest risk. Any suggestions or offerings for people around how to navigate those conversations? That's an open one. Any of you. I don't want you to get into the hot seat, right. Dr. Jarlais. I made you blush talking about sex, but our people are having sex.
I've been talking about sex since I can't remember when I started. But anyway, it is good to have sex with people you can talk to, and openly and honestly. The World Health Organization has recommended against anonymous sex, where you don't know the person and probably can't talk to them. Recommendations against having sex are somewhat difficult to follow, but this would be a time when you would want to limit your number of sexual partners, limit them to people you can talk to about the issues of monkeypox and sexually transmitted diseases as a whole. We do have a certain amount of time to try to bring this outbreak epidemic under control. There is a possibility that we could get it back to very close to 0 cases in the US, although we would have to really deal with it worldwide. But we did stop SARS-1. We used effective public health control measures, and SARS-1 is no longer a threat to humans. So we need to try to put as many resources into controlling this outbreak as possible and as rapidly as we can. And there is still a window of opportunity to get this under control. In the meantime, limiting your number of sexual partners and limiting them to people you can talk to about the issue would be a good idea.
Wonderful. One of the things, since you mentioned SARS-1, that is my understanding about a part of why we were successful is most of the people, if not all of the people who had SARS-1 were symptomatic. And that became a sore spot in our, ability to sort of mitigate and eradicate COVID early in the pandemic. Do we know are there people who are getting monkeypox who have 0 symptoms but are able to transmit? And that's for Dr. Kapadia, Dr. Onpad. If we're not sure, fine, then we want to have a different conversation about recommendations if you have a known exposure or you have something happening on the skin and you're just unsure whether or not it's monkeypox.
So my understanding is that there are asymptomatic cases. Whether they're transmissible during the asymptomatic phase, I think I'm not quite certain, but maybe Dr. Umpad or Dr. Jarlais has some better knowledge about that. But I do know that there are asymptomatic cases, so that's something to know. The only point I wanted to add to what Dr. Jarlais said is that right now we don't have evidence on whether clear evidence on whether monkeypox is transmitted through semen or vaginal secretions. So this is not a sexually transmitted infection, right? It's transmitted because of close contact. So you don't have to just have sex with someone in order for this to be a transmitted disease. It's about close contact. So we're talking cuddling, spooning, we're talking hugging, right? All those things that we want to be able to do with our close partners or someone that we want to be close with. But for right now, we can't. And that's hard. And those are hard conversations to have. And we can't shy away from the fact that that's a hard conversation to have. Yeah. But it's what we're dealing with now. It's not just about sex, but it's about close personal contact. So I wanted to put that out there.
Do we know much about how long monkeypox might reside in sheets or on blankets or on surfaces? Do we know? And is this it makes me think of like bed bugs, right? You had to wash everything or dry everything. It was really the heat that killed bed bugs. I'm going to put a pin in that, but I'm going to ask you guys, I want to come back to that. Unless somebody has a burning thing like, no, this is what we do know. And again, it could be evolving. What do we know about how long it might be able to live on these surfaces or in sheets or on your clothing?
I would say we don't really know, but the best short answer right now would be until you wash those sheets and clothing.
Gotcha. So
I just wanted to add one other thing about transmission during intimate contact. Condoms are not going to prevent monkeypox, right? Because as Dr. Kapadia said, and I said earlier, we're actually not sure if it's transmitted by vaginal or secretions or semen, but we do know that it is transmitted by close physical contact. So we don't wear body condoms, right? That's not a thing. So condoms are not going to prevent monkeypox. They do prevent other things, absolutely. But if you're worried about monkeypox and you want to have an intimate encounter, do not rely on condoms to prevent that. And to answer your more recent question, I agree with Dr. Jarlais. We're not really clear how long it stands on surfaces. I haven't seen very much data on that, but washing surfaces is probably your best bet right now.
Okay, great. we got about 10 minutes left. So I want to do just a little there. And actually, I'm going to do a bigger question. And then I'm going to do a couple rapid fires so we can answer as many of these questions as possible. So we are all, faculty in this amazing School of Global Public Health at NYU. We saw very wide-ranging responses to how institutions and universities managed COVID. Some went back, some, sent people home right in the beginning, some sent them home later. Is there anything that we know and understand that we should maybe be thinking about as leading academic institutions about what we should be doing, or what kind of information we need to be sharing, or any kind of precautions that you think we need to be putting in place? Is it really just good information dissemination? Should we also sort of up our level of testing? Do we need surveillance programs in universities or in workplaces? Just any ideas that you all might have around that.
Yes, some ideas. I think we need to continue functioning as universities. We shouldn't send people home. We shouldn't try to do remote learning with all those problems. The primary route is prolonged skin-to-skin contact, but we should enable our student health services to do testing for people who suspect they might have been exposed to monkeypox. That there is enough skin-to-skin contact among students that we should have readily available testing for monkeypox.
Okay, awesome. Anybody want to add anything else to that about, for employers, workplaces, institutions, schools, anything like that we need to be thinking about?
I think it's helpful to remember that during COVID, so before COVID, a lot of us would come to work sick, right? And for some, it was a point of pride. I don't feel well, but I'm still coming into work. And then COVID showed us that that's probably not a good idea. And the same goes for monkeypox. It's probably not a good idea if you have a rash to come into work until you figure out what's going on. And so it would be really helpful for companies and organizations to make sure that their sick leave policies and their vacation policies support that, so that they can reduce transmission among their employees.
Okay, great. All right, I want to do a few rapid fire questions, and I'll just trust you all to be off of mute and jump in and answer. Can children get infected?
Yes.
Yes.
Can you get reinfected?
Probably not. When with smallpox, an infection provided lifelong immunity. It is probably the same for monkeypox, but I think we'll, as this evolves, we'll have a better sense of that.
If I had smallpox, can I get monkeypox?
Probably not.
Probably
Potentially,
not.
but potentially. In the 2003 outbreak, some of the people who got monkeypox had been previously vaccinated for smallpox. And so it's probably not common, but I don't know that we know for sure. Particularly in the US, not many of us have had smallpox.
No, not almost nobody has
Yeah.
had smallpox in the US who's
Okay.
currently alive.
The time from the vaccinations, Dr. Ampad, was so long ago.
It was.
There was probably a lot of waning immunity.
Yes. So from the smallpox vaccination program in the US stopped in the 70s. It
Right.
stopped in the 80s in some other countries. Some of us, I was vaccinated in 1995, but that's because I worked in a Vaccinia lab. It's unclear whether or not I'm protected from monkeypox, even though I've had the vaccine in the last 30 years. So just something to keep in mind. I wouldn't count on it. Let me put it that way.
So probably not, but possibly. Is that a fair? Okay, great.
Smallpox vaccination is different than a smallpox infection, though, I would just say. That's all.
Yeah. Okay, gotcha.
Yeah.
All right. Do antivirals work for monkeypox?
There is an antiviral medicine called TPOXX that is effective for smallpox and is probably effective for monkeypox.
All right, this is not a rapid fire yes or no, but I hope you can give me a short answer. If we've had monkeypox in the world for so long, why do we seemingly not have more information, specific antiviral vaccines?
I think it goes back again to which countries have borne the burden of this disease, and where and who within those countries has borne the burden of this disease, right? It's a largely neglected condition. Research has been done in Western and Central Africa. It's not been a condition that we've seen outbreaks of. Well, we saw one outbreak in the US in 2003, but that was localized. It was Wisconsin and a couple of other states. It was animal to human, and it was quickly stopped. But because it hasn't been on our soil, it hasn't been our problem. And now it's on our soil and it's our problem.
On the other hand, I'll just add that we do know a lot about one particular pox virus, which is Vaccinia virus. There is a whole lab at NIH that is dedicated to Vaccinia virus research. That's actually where I did an internship when I was a student. And there's a lot of overlap in pox viruses, but not perfectly. And so I think the hopeful news is the folks that have been working on Vaccinia for decades can probably inform our understanding of monkeypox and perhaps contribute to our understanding of what's going on now.
Awesome. All right, we're going to close out. But before we do, I want to give you each about 30 seconds. And I'm going to start with Dr. Jarlais. As the NYU School of Global Public Health, we have a fundamental belief in health as a right and not a privilege. And some of what we've talked about today and some of our other work, we know that unfortunately people don't experience health and access to high quality healthcare and everything that one would need to be healthy, from safe and potable water to safe and secure neighborhoods and quality housing and livable wages. We just know that that stuff's not equally and equitably distributed. What might you say to us, Dr. Jarlais, that we should have our eye towards in an equitable response to this potential public health threat?
I think we have to think in terms of public health and community health, that the health of individuals depends upon the health of the community. I mean, AIDS taught us that, COVID taught us that, monkeypox is teaching us again that no matter how wealthy we are, we're not going to be able to protect ourselves if the community is not protected. So we need to think really in terms of investing in the health of the community and not trying to protect ourselves as individuals.
Gotcha. Our problem, not your problem or my problem. Awesome. Dr. Kapadia, your final words.
I would add on to Dr. Jarlais and say, think community, but think of our global community. Think about not just our responses here, but coordinating responses everywhere so that what happens someplace else isn't just a someplace else problem. I'd also add that what's happening to human populations is a result of what's happening to our planet, right? And so we think of population health, we have to also think about planetary health, because these problems, these diseases spreading from animal populations to human populations are not going to go away. And we're probably going to see more of them if we don't start thinking and caring more about our planet's health.
Awesome. Thank you. Dr. Onpad.
I would just add that unfortunately, health disparities are often predictable. So, you know, in COVID in December 2019, there were no health disparities, right? But very quickly, as transmission started to happen and access to care started to play out, we started to see that there were some communities that were less likely to get treated, they were more likely to die. Where we are with monkeypox right now, we're at a point where we could prevent disparities, we could prevent inequities. I suspect we'll end up with inequities because our systems are not as nimble as we want them to be, and they're not as equitable. But we could, if we worked really hard to do that. So going back to what Dr. Jarlais said and what Dr. Kapadia said, locally or globally, we really need to invest in communities to make sure that they remain healthy. And then the other thing I would just add is, you know, information on monkeypox is emerging and evolving. And so what we say today is what we know today. But 2 weeks from now, we could learn more information and our messaging might change. It's not because we don't know what we're doing. It's because we're getting more information and then we want to share that with you.
Wonderful. I want to just acknowledge and honor and appreciate all of you. I know many of you have been working and burning the candle at both ends, very much on the forefront of many public health issues that predated COVID. You all rolled up your sleeves during COVID. And I just appreciate you for keeping yourself up to speed and being at the forefront of this, hopefully, crisis that we can bring to a close. On behalf of the NYU School of Global Public Health, I just want to thank all of our attendees today. We're going to be coming back at you. We're going to do our best to add to the conversation as a trusted, credible messenger, consistent with our stand for a world where everybody truly experiences their health as a right, as a birthright globally, and not as a privilege. Thank you again. My name is Deborah Holden, Dr. Danny Ompad, Don Jarlais, and Farzana Kapadia for being my partners in the fight. And we will see folks sometime soon. Thank you.